Cardiology consults happen all the time in both inpatient and outpatient settings, and one of the diagnoses that is often ascribed to atypical chest pain presentations is this one right here, costochondritis. What is it? How do you know that your patient is feeling costochondritis versus anything else? How do you know? How do you delineate that? Very, very easy to determine. Lock in and let us learn about costochondritis. Chest pain. Chest pain can come in many forms and can be attributed to many sources because there are a lot of structures that are housed inside the chest. This one, though, costochondritis, pretty clear cut in presentation. Costochondritis is no respecter of persons. It doesn't matter if you're male or female. It doesn't matter what ethnicity you are. It doesn't matter what age you are. Costochondritis is no respecter of persons. It occurs in everybody the exact same way. Costochondritis, often described as a sharp chest pain, and that pain typically around the sternum area, but it can occur anywhere in the chest wall. Sharp pain, not worsened by physical exertion of any kind, strenuous or non-strenuous, has no reflection or no bearing in this whatsoever. What does make costochondritis worse is taking a deep breath in. That is called deep inspiration, coughing, laughing, anything that causes that chest to expand, that rib cage to expand. So I saw a patient in the office not very long ago for this very same reason, and everything that I just detailed to you as far as symptoms is everything that she told to me. So I said to her, explained that her EKG was normal. She wasn't having any signs of any sort of angina, no angina symptoms, nothing. And mind you, she was very young also, she was in her 20s. So what are the chances of a 20-something-year-old having coronary artery disease to the point where it becomes obstructive and ischemic and causes angina symptoms? Not very likely. Nonetheless, she did say that when she first noticed it when she took a deep breath in when she was trying to yawn, and then she just felt like a catch in her chest, and it freaked her out to the point where she went to the emergency room, which is fine. You seek medical attention if you feel like something is really the matter. The emergency room team, again, did their respective workup. Troponins were negative. EKG was unremarkable. Chest x-ray didn't show any compromise cardiopulmonary whatsoever, so they referred her over to cardiology. Nonetheless, I asked her, are you aware that the bones in the rib cage, when you take that yawn in, like you said, you can literally see your chest expand when you take that deep breath in and then kind of contract when you let that breath out? And she said, yeah. I said, you realize that bones don't stretch? And it was like a light bulb moment hit her. She was like, you know what? You're right. Bones don't stretch. I said, yeah, so there has to be something else in the rib cage that is allowing for elasticity to let that rib cage open up and expand like it does and then contract when you let that breath out. And she's kind of looked, and I pulled up her chest x-ray, the image of her chest x-ray, and I said, pointing to certain spaces. I said, you see this area right here? She said, yeah. I said, there's cartilage that connects your bones to the bones of the ribs to the actual sternum. There's cartilage. Cartilage has elasticity in it so that when you take that deep breath in, stretches. And she said, oh my God, that's where I'm getting this pain from. And the dots came connecting together for her. That said, nurses, student nurses, new graduate nurses, if your patient has been consulted for cardiology evaluation in the hospital setting, and cardiology has not yet come to the floor, and your patient is complaining of chest pain, by all means, I am not telling you to ignore your patient's chest pain and just dismiss it. Don't do that. But ask them, ask your patient, what makes your chest pain any worse? Is it worse if you take a deep breath in? Is it worse if you cough? Is it worse when you laugh? And if they say, yeah, as a matter of fact, it is, you have an argument for costochondritis. Now, cardiology is going to come in and do their respective workup, maybe an echocardiogram, maybe a stress test, just to rule out any sort, or definitively rule out any sort of anginal component to this. But if your patient is complaining of sharp chest pain, non-exertional, worse with deep inspiration, coughing, or laughter, you have a very strong and valid argument for costochondritis, and this is not heart related. Any questions? Chime in, give me feedback, hit your buttons. New to the classroom? Join us. Just hit that plus sign right there. Class is dismissed.